So today, my title of my talk is about decolonizing global health and drug policy. But what I'm actually going to be talking about is anti-Blackness in global health and drug policy. So let's start with some questions. I can just about see most of you in the audience. Put up your hand if any of these apply to you. Can you go to a store and be able to shop without any of the store employees following you around or harassing you? Yep. Can you open a newspaper or turn on the TV and see people of your color represented in those media? When you were thinking about, when you're taught about your history and your culture, you were taught that it was people of your color that made it what it is today. So these are all examples of white privilege. It's a term coined by Peggy McIntosh. And she said that I was always taught to understand that white privilege, that racism was certain acts of individual meanness, not that it was an actual system of oppression. And so as we go through today, I ask you to be aware of your white privilege. The murder of George Floyd in 2020 resulted in revelations about the systemic racism that Black, Brown, and Indigenous people face all over the world. It was a time where we were confronted with systems that didn't work for Black, Brown, and Indigenous people. We were confronted with the fact that white supremacy has touched almost every country on earth through colonialism and its allied systems of slavery and apartheid. As Black people, we try to fit into the dominant culture. We try to master the tools of the dominant culture. We go to the right schools, we get the right education and degrees, we dress the part, we speak the language, but we shouldn't have to. So I've been working in global public health for about 25 years now. And I started because we had won I'm a South African. We had won the war against apartheid in South Africa, but then everyone was dying of HIV and AIDS-related diseases. And I thought, how is this possible? How do we allow this to happen? Because in the West, in the United States, in North America, and in Western Europe, they had antiretrovirals so people could stay alive. But in South Africa, people were losing the battle against HIV and AIDS. So many people were sick and dying unnecessarily, and I wanted to be able to change that. And that's one of the reasons why I started working in global public health. One of the things I've noticed over the past 25 years is that our systems, our health structures do not work for us. They do not work for Black people, brown people, or Indigenous people anywhere. And so I started to think, well, where did global health come from then? Where did we get these structures? Well, it came from tropical medicine. It came from the fact that colonial powers wanted to ensure that white people in their colonies did not die of malaria or yellow fever. So it came from an idea that they needed to protect their resources, which included human beings in their colonies. And so what is the difference between where we started with tropical health and where we are today with global public health? Well, in terms of the structures, absolutely nothing. Nothing has changed, because today our global health structures and our programs still operate on the notion that we need to provide money to somebody else. And the priorities are set by the donors, and they're set by countries, and they're set by people who are mainly white in the North. It allows us to talk about people as beneficiaries of our money, as targets of our interventions. It allows us to look at a Black, brown, or Indigenous life as an outcome or a goal. It allows us to make money off of Black bodies. And I include myself in this because I've worked in the global North now for 25 years, right? We make money off of Black bodies in the way our global health system and our structures work. So white supremacy is part of every part of our work in global public health, because it's in our systems. And yes, granted, we talk about equity and inclusion and country ownership and stakeholders and bringing everyone together. But what we don't talk about are how our structures and our daily operations are actually racist, actually sit in white supremacist culture. And that's what we need to change. So what does that look like in terms of health? Well, there are quite a few different aspects when you come to racism and health and white supremacist culture in our systems. And one of the best ways to think about this is to start with, what is the impact on my body? What is the impact on a person who is Black, brown, or Indigenous? Well, systematic reviews in the United States and Australia have found that racism has an impact on our mental health, producing depression, anxiety, psychological stress. But not only that, it actually has an impact on our overall general health in the types of diseases that we acquire and the conditions that we face. So you could be me, Colleen Daniels, ordinary woman, Black woman from South Africa, or you could be Oprah Winfrey, very influential Black American woman, and the impact of racism on our bodies is the same. Our access to services might be different, but the impact on our bodies is the same. And so we need to realize that racism is not just an individual act of meanness. It is systemic, but it also has a physical impact on us. And we see this when we think of the way that pain, for example, pain assessment is treated and diagnosed in people who are Black, brown, or Indigenous. So in the United States, in 2016, there was a study of first and second year medical students, and 50% of them believed that Black people had thicker skin and had less pain than white people. And this came from an idea and a concept that a plantation owner, a slave owner who was also a physician named Thomas Hamilton came up with when he was experimenting on one of his slaves named John Brown, where he would blister his skin to prove that Black skin was thicker than white. So those biological biases come through in all parts of our work. We see it in the in our diagnostics and our treatments. A lot of diagnostic tools don't work on Black, brown, and Indigenous people. It doesn't work on our skin color. Treatments don't work on us because diagnostics and treatments today are set against a standard for white men. Not even white women, white men. And that is something we need to also look at and change. It means that we have to understand at all the different levels what racism means on our health. So, where are the global health organizations? If we have an impact on Black, brown, and Indigenous people in our bodies, and we have an impact and we see systemic racism in our institutions, what does that actually look like, though? Well, it looks like this. You have 38% of all global health organizations in North America. You have a whopping 46% of them in Western Europe. And yet all the work that they do is for the global South. If you look at Africa, where so many interventions and programs are, for example, HIV and tuberculosis, where in our areas that I work in, it's 7%. If you look at the governing bodies, so the boards of these organizations, 77% of them come from high-income countries. In funding bodies, that rises to 82%. And it means that only 2.5% of board seats are actually people from low and middle-income countries. And out of everybody who sits on a board for these organizations, 51% of them are either American or British. So that's the kind of systemic white supremacist institutions we are dealing with today. So if all the global health organizations are in the North, where does the money go? Well, if you looked at the National Institutes of Health Fogarty grants in the United States, you'll see that 70% of the money and in the grants go to American and high-income country institutions. At Wellcome in the United Kingdom, you have 73% of the international portfolio supporting UK-based firms. Almost 80% of USAID's contracts and grants go to American firms. And a whopping 88.4% of grants for that under Bill and Melinda Gates go to the global north. So not only do we have the power sitting in the north, but we have control of the money sitting in the north, which means that the priorities are set by the donors. So you can go into Benin. I'm going to pick Benin because I spoke to a colleague there a couple months ago, and I said, tell me about your priorities. What are they? And they listed the priorities, and I said, well, then tell me what the programs are. And they said, well, we don't have any programming because no donor wants to fund that. But we are going to do these programs because this is what the donor will fund. So that idea of country ownership, that idea of engagement with people in countries is actually a fallacy. Because the global north wants to see and maintain a system that is set on charity and philanthropy, on aid and donations, development assistance, saviorism, and dependency. But in the global south, the way we want it to be systematically incorporated in human rights, in equity and social justice, in reparations, something nobody in global public health and in drug policy, which I'll talk about in a minute, wants to talk about, in autonomy and respect, in self-determination and self-sustenance. And I was talking about this to a colleague in another organization a few months ago, and she said, well, she's the executive director of this organization. She's a white woman. And she said, well, do you want me to leave my job? And I said, yes, actually, yes, that's what you need to do. You need to consider how you transition out of your position in 3 to 5 years to enable someone from the global south, where all your work is, to be able to take that position. And if you can't do that, then you should at the very least, consider how you can have a co-executive director who is from the global south. So it doesn't mean that white people are going to lose out on something. It just means that we all win at the end. So you might think that these policies and systems only work in global public health. Unfortunately, no. Drug policy is probably one of the most repressive that we've ever seen. And in 1994, John Ehrlichman, who was an assistant secretary for domestic affairs under the Nixon White House, he was talking about how they had managed to control the anti-war left and the civil rights movement, which Nixon saw as two of the biggest problems in 1968 when he took over. And so John Ehrlichman said, well, we couldn't make being anti-war or black illegal. That wouldn't work in that time. But what we could do is we could associate the anti-war left, they call them the hippies, with cannabis. And we can associate the blacks who are working on civil rights with heroin. And what we can do is we can criminalize those drugs. So we can criminalize substances, which would then enable us to go in and criminalize those populations. We could then break up their meetings. We had a legal basis to break up their meetings. We had a legal basis to vilify them on the news every single day. This drug policy that set the stage, was really set by the United States, has been exported around the world. And we see this in so many countries where that drug policy that was situated in oppression and subjugation and racism is now being implemented globally. And it's wild because, you know, if you think of the history, for example, of Western countries, so many of them went to war in the 1800s and early 1900s to protect the drug trade because they were making so much income from it. And you think of the Dutch in what is now Indonesia, and you think of the British going to war against China to protect the opium trade because they were making that much money. And then the United States came in, and American imperialism took over because the United States now had colonies. And they could see that they really couldn't control people in the Philippines, and they couldn't control the natives building the canal in Panama because people were using substances that they didn't want them to. So they started the criminalization of those drugs, cannabis in the Philippines, cannabis and other native drugs that native indigenous people used in Panama. And this was their way of being able to control those populations. So this system and policy of control is what was then exported around the world. And we see it, for example, in disproportionate policing of Black, brown, and indigenous people, where in the United States, Black people are 5 times more likely to be incarcerated than white people. In the United Kingdom, it is 8 times more likely that a Black person will be stopped and searched than a white person. In Rio, in Brazil, in 2018, 80% of all people killed by police were Black. So what does that mean for you in this room? Well, it means you have to be on a journey from active allyship to co-conspirator. And what does that mean? Well, it means, today I'll give you a good example. If you're an active ally, then you would support donations of COVID vaccines to the Global South. If you were a co-conspirator, you would ask for patents and technology to be transferred to the Global South so that people in the Global South could manufacture their own vaccines. It means that you have to choose to become anti-racist, vocally, verbally, actively. I used to work at a UN agency called the Stop TB Partnership, where I faced horrific racism. And I wrote an article about it in Medium. It was then picked up by the New York Times. And there was a big investigation. And let me tell you what happened to the racists and the bullies who, because I raised the racism, had an issue. And they they're still in their jobs. They're still there. I resigned because I couldn't take it anymore, but they're still there. And they still get funding, and their salaries are still paid by American and Canadian taxpayers. So unless you decide to choose to stand up and say something and choose to be a co-conspirator, things will not change. And it means that, yes, we all do that cost-benefit analysis of, is this something that I can speak up about? Will I be hurt? Won't I be hurt? And a lot of white people come up to me and say, oh, but it's so uncomfortable. And I say, well, get comfortable with your discomfort, because that's how we feel on a daily basis. And so Lila Watson, who is an Aboriginal elder from Australia, said, if you have come to help me, you are wasting your time. But if you have come because your liberation is bound up in mine, then we can work together. And that's what you can do. You can choose to be part of the co-liberation of all of us in the same boat together. You can choose to be a co-conspirator. And I just want to say thank you to some amazing people who are doing work, a lot of beautiful and amazing intellectual minds that I just want to mention here. Thank you all so much for having me.
Good job.